Welcome to the Exercise is Health podcast, where we're talking about exercise, health, and the interconnectedness of the two. We are your hosts, Charlie
and Julie,
and we will be coming to you every single week from our studio, Muscle Activation Schaumburg.
Hey, welcome back, everybody, to the Exercise is Health podcast. We are your hosts, Charlie
and Julie,
and we are coming to you from our studio, Muscle Activation Schaumburg in Schaumburg, Illinois. Now, at Muscle Activation Schaumburg, we believe that your health is your most valuable asset. Your health is one of the biggest influencers of the quality and quantity of time that you have. And while there are many aspects of health, our expertise is exercise. Exercise has been proven time and again to not only improve your health, but also increase your longevity and improve your quality of life. But we know that exercise is not the only piece of the puzzle, and that is why we are bringing you a phenomenal guest today, none other than Dr. Thomas Obermeyer. Dr. Thomas Obermeyer is a board-certified, fellowship-trained orthopedic surgeon specializing in shoulder surgery and sports medicine. He is recognized as a leading shoulder subspecialist, offering state-of-the-art arthroscopic repair and complex shoulder replacement and revision shoulder surgery. Dr. Obermeyer's care philosophy centers on compassion, open communication, and individualizing treatment, especially when surgery is an option. Dr. Obermeyer, thank you so much for joining us here today on our show.
Thanks for having me, Charlie. And Julie.
Absolutely. So tell us more about your background. How'd you get into medicine? How'd you get into orthopedics? And, what has been your history kind of growing up and going through the whole medical school process?
Sure. So I grew up in Alaska, and I was initially intrigued by the sciences. I always had an interest in medicine and biology. I ended up pursuing a biology-based curriculum at RPI, as we talked about previously briefly. Ended up staying in the Albany upstate area for medical school, and I was always really inclined towards the surgical fields. I always had an interest in anatomy, and I was also an athlete, which also had me interested in athletic-based injuries. I initially chose orthopedics probably in large part based on my experiences shadowing and interacting with other orthopedic surgeons. Sure. I really fell in love with the field. I really like the hands-on approaches and the ultimate, improvement in the quality of life, improvement in function and pain, with really interesting surgical applications, which is really what I've kind of focused on and really have developed a passion for. I pursued my orthopedic residency in the Chicagoland area at Loyola, and then I did a shoulder surgery fellowship in Manhattan. Awesome. Spent some additional time in France, so I've kind of done a fair amount of training in orthopedics, and I really enjoy the field.
That's really cool. So was it something where you had sustained injuries yourself early on and that got you interested in it? Or were you just intrigued from the athletic background?
I would say it's probably more the athletic background. I was fortunate enough to have had only relatively minor orthopedic conditions that were relatively temporary and short-lived. But I think a lot of it was the interest in athletics and interactions with peers that also had injuries. I would say probably developed my initial interest in athletic injuries. And then, again, a lot of it, I think, was my experiences in interacting with other orthopedic surgeons and getting into the field and realizing that it was something for me.
Very cool.
That's awesome. So how did you get interested in the shoulder specifically? Because it seems like that is like your thing. That is your specialty.
Right. I think a lot of it was based on probably the heterogeneity of problems that are specific to the shoulder. I think shoulder surgery itself is a field that encompasses the spectrum of arthroscopy, where you get to interact with athletic patients, many of whom have athletically sustained shoulder conditions, many of whom are younger, to patients that are a little bit older that develop soft tissue abnormalities, including the rotator cuff, and then it also encompasses another kind of section of replacement surgery, as well as fracture care and other traumatic injuries. So it's a relatively diverse field, and it was my decision to pursue it was probably also based in part on my experience with mentors that have guided me along in my interaction with the patients themselves. I felt that it was something for me, and I really enjoy the shoulder.
Very cool. That's really neat. So the population that you work with today, is it predominantly athletic based, or are you working with people of all different kinds of demographics?
Sure. So I think if you look at any shoulder surgery practice, I would say the most common complaints are in patients that are a little bit older. I'd say that kind of the probably, if you look at the distribution of patient age, it's probably more commonly patients between the ages of 50 and 65 years of age. And then there are certainly patients on the outlier. There's definitely a large population of athletic patients, but if you look at the overall numbers of patients that present with shoulder-related complaints, they're probably seen in patients a little bit older. I see I'm fortunate enough to treat patients pretty much of all ages, many of whom are younger in an athletic population that have sporting-related injuries. So it's somewhat of a diverse patient population in that regard. Yeah.
Very neat. I bet that keeps things interesting for you, seeing.
It does.
Yeah. Wonderful.
So when you're saying most of the people you see, or the common people coming in with shoulder complaints are between 50 and 65, you said it's a little older. What are the common complaints and what are the common issues that are present at this age?
Yeah, so I would say by far and away one of the more common disease processes that affects the shoulder, that is somewhat of a degenerative process, affects the rotator cuff specifically. There are other complaints specifically in younger patients that can include the rotator cuff, but more commonly can involve some of the other soft tissues, including the labrum, the biceps tendon. As you start to get patients that are a little bit older, as you can imagine, there are other degenerative processes specifically affecting the joint of the shoulder, the glenohumeral joint, which encompasses, starts to look at arthritic-based care and shoulder replacement type surgery. And so I would say that the rotator cuff is a large portion of shoulder pathology that's seen in a shoulder practice.
Yeah, no, that would be something that I think we would echo as well. A lot of people that come in here that have shoulder-based issues have been told that they have, rotator cuff issues. So I think, across the board, that's something that's very common. What do you see as kind of contributing factors to that? Is it simply age-related, or are there other kind of activity or lifestyle things that seem to contribute?
I'd say it varies depending on the actual patient. I think that if you look at the rotator cuff specifically, it is known to undergo this degenerative process. Now, there are certain factors that are inborn or kind of that predispose certain patients to developing a degenerative rotator cuff problem. We do see rotator cuff abnormalities in patients that otherwise you might not expect. For example, patients that are very active weightlifters or that have sustained an injury or a traumatic tear. Some of these patients that have other injury patterns that aren't necessarily explained based on a genetic or an inborn kind of predisposition process. But I would say that in general, rotator cuff disease as a disease process is probably more seen as somewhat of a degenerative process that occurs not necessarily as a result of age, but is seen more commonly as patients get a little bit older.
Interesting. And so when you say rotator cuff disease as like a disease process, what kind of processes are happening with the rotator cuff? Is it more than just the rotator cuff is inflamed and unhappy, or what's going on there? Are tendons getting weaker, or?
Yeah, so the rotator cuff disease is hypothesized to occur via a couple of different mechanisms, one of which includes a gradual degenerative process occurring at the actual tendon insertion of the rotator cuff. And then secondly, what starts to occur relates to the anatomy of the shoulder, where if you look at the arch of tissue on top of the rotator cuff, specifically the coracoacromial arch, which is a series of tissues on top of the rotator cuff, patients can develop a spurring formation and a so-called impingement process, where the rotator cuff undergoes a gradual kind of abrasive degeneration, which can then lead to partial and then full thickness tearing. And so there is some anatomical factors that do contribute to rotator cuff disease, but we do think that a lot of the initial kind of inciting event is really an intrinsic degeneration of the tendon insertion of the rotator cuff.
Interesting. Very interesting.
Do you find, I think in the personal training world, we have this hypothesis that the changes in soft tissue, like, the tendons, the ligaments, the muscle changes, can contribute to how the bones are changing. Like you were just saying, the spur formation. Is that a valid thought or, line of thinking that these soft tissues can eventually lead to those more bony-like tissues growing and impacting?
The suspicion is that yes, absolutely, there is a dynamic instability consideration with the development of rotator cuff pathology. The rotator cuff, if you look at the actual, a lot of it relates to the anatomy of the shoulder. The shoulder, if you look at the anatomy, just the osseous anatomy in terms of it, being a non-constrained joint. In other words, the humeral head is a kind of is a ball that sits in a relatively shallow dish, and the way that joint is stabilized is really dependent on the soft tissues,
Right.
and that's in contradistinction to some of the other joints. For example, the hip joint, that's a relatively constrained joint. In other words, there's a large bony constraint to disallowing the joint from moving around. And what happens in the shoulder is that the function of the shoulder is very dependent on the dynamic stability that's afforded by the rotator cuff in terms of balancing couples of forces in different tissue planes. For example, in the coronal plane, the top-down plane, and the transverse front-to-back plane. And when those force couples start to become disrupted, in large part because of a degenerative process, it undergoes this progressive degeneration and tearing process. And so that also gets to the occurrence of the progression of these rotator cuff tears, and why once a tear is diagnosed, they typically don't just go away. It's actually quite the opposite, in that these tears gradually progress as patients age.
Interesting. And so as they're progressing, what's the means of intervention? Then is it a surgical intervention? Is it physical therapy intervention? Is it a stop all activity kind of intervention?
Sure. The goal of treatment is really to allow patients to resume their activities and their quality of life. Patients oftentimes will initially, it depends in part also on the extent of the disease. So if you look at rotator cuff disease, on the early stages of the disease process, which really encompasses partial tearing, maybe a little so-called bursitis, which is inflammation on the tissue around the tendon itself, those patients are very good candidates, and we have good evidence to support physical therapy and exercise-based treatment for them, and they will have durable improvements in the long term with their shoulder problems, specifically pain. When you start to develop more significant structural tearing in the shoulder, where the tendon is fully detached from the bone, the analogy is like living with a hole in your sock. There's a hole in the tendon. It's really not going to go away.
Sure.
And we do know, based on our experience, that there's a large fraction of those patients that in the long term will experience progression of their tearing or disease process. And so some of those patients, not all, but they can become candidates for arthroscopic repair of the tearing.
Very cool.
So if the structure is part of the reason why the tearing is occurring, do you have to also manipulate the structure then when you're repairing the tissue?
Sure. So, as we were talking about, there's some of the tearing process is actually caused in part by this so-called impingement on the upper part of the shoulders, that arch that we were discussing previously. And yes, there is a part of the arthroscopic treatment is really so-called decompressing that area. So what we do is we do some of the bony work on top of the tendon tear to actually decompress the tear, to allow more space, if you will, for the tendon. It also improves the healing of the tendon itself and prevents it from recurring. So yes, that is part of the arthroscopic treatment.
Okay, wonderful. And so by addressing both the soft tissue and the structure, you see that reoccurrence is very limited?
Correct. So it depends in part on the extent of the tear. Now, if you have someone that comes in with a massive tear, which can occur, and at that point, what happens is that the tear starts to involve multiple tendons, and the tear becomes substantially retracted. You can imagine that the tissue has not been attached to its normal insertion site for sometimes many, many years.
Sure.
And as that occurs, the tissue not only degenerates, but also the muscles that power the tendon can become atrophied and degenerative. And sometimes we intervene to prevent these things from happening. But in those patients that have more advanced forms of the disease, you can imagine that the repair, sometimes the healing rate is not as favorable as it might be if someone were to come in when the tear was a lot smaller.
Sure.
But certainly patients that come in with smaller tears that don't have any atrophy of the muscles, that have relatively preserved function of the arm, they can have a very, very favorable healing rate and ultimate improvement with arthroscopic treatment.
That's awesome. Now, do you see this process, as far as the disease process, affecting all muscles of the rotator cuff equally, or are there certain ones, whether it's supraspinatus or something like that, that tend to undergo this process more? By
far and away, the most common part of the rotator cuff anatomy that becomes diseased is actually the front part of the rotator cuff that is known to impinge. So that would be the supraspinatus tendon. And so we see different tear patterns. Some of them, and right now we're speaking more of degenerative tears. Now there are traumatically induced tears that are kind of a different discussion altogether. But these more degenerative type tears, yes, do most commonly affect the supraspinatus tendon. the subscapularis and infraspinatus can kind of secondarily become involved. But yes, it certainly does most commonly affect that area of the shoulder.
Interesting. And so with that in mind, are there any kind of lifestyle things or activity-based things that people should be avoiding, should be, you know, as a age they should do more of, they should do less of in order to prevent this?
So the hypothesis is really that a lot of the intrinsic kind of predisposition that we were discussing is really unchangeable. In other words, there are patients, for this reason, there are a lot of patients that present with, you know, tears that we see on both sides.
Sure.
But you know, there's no real way to change your biologic makeup. So there are patients that do have very high demand activities. Some of whom are in labor-based professions that do a lot of repetitive resistive overhead activity. Some patients do very heavy weightlifting, for example, that place large tensile torques and forces through the rotator cuff. And we do suspect that some of those patients may possibly have tears that are contributed by those activities.
Gotcha.
But I would say by far and away the more common situation is that a patient it's just bad luck and possibly a genetic component that causes the tear to develop.
Oh, very interesting.
Yeah. I think one thing we see a lot here in our practice, just because we focus solely on exercise and making sure that muscles can be as strong and used appropriately as possible, is that with the shoulder being such, as you said, an unconstrained joint, and that's kind of the beauty of the shoulder, we get so much motion there. But the trade-off is that it's so controlled by the soft tissue, by the muscle tissue. And we see a lot of people that either are chronically overusing some tissues and chronically underusing. And so we find a lot of times when we start helping people exercise appropriately for what they're able to do, that a lot of balance kind of returns, and that can alleviate some stressors. But I wasn't sure if you had recognized, do you notice that with this degenerative process, do you notice that people that are highly active seem to get it more, or is it still what you had mentioned, just kind of either bad luck or genetics or just simply age? It can go to someone that's active or really inactive.
Yeah, that's a great question. I would say more than likely there's somewhat of a combination of both. In other words, you have an individual that may have their particular anatomy may predispose them. They may have a genetic predisposition to developing a tear. And from that standpoint, perhaps they're enrolled in an activity or an occupation that really puts high demands on the shoulder. Those patients probably would be more likely to undergo, this progressive tearing process. Whereas you may have someone that has a similar kind of background and makeup that really doesn't, perform many of these activities and may never have a shoulder problem.
Sure.
So the suspicion is that probably it's a combination of those things.
Okay. When people come in and they're having shoulder issues, are there recommendations that you will give for them if they are, say, at the moment either not a candidate for surgery or looking to avoid surgery for the time being, or trying to prevent it, the onset of the disease processes more than is necessary? Are there certain things that you would recommend people again do or avoid, or anything like that?
Sure, that's a good question. So without question, there are patients that come in with structurally significant tearing processes that we do sometimes talk about early intervention with arthroscopy. However, there is a large fraction of patients that either are good candidates for non-surgical treatment, where we talk about avoiding certain activities that put large forces or strains through the rotator cuff, specifically activities that involve reaching or positioning the arm away from the body, lifting large objects. Some of the activities may include, lifting a large heavy purse or a bag out of the backseat of a car with the arm in somewhat of an extended position, lifting a large object with the arms away from the body. Those activities we suspect put a large tensile force through the rotator cuff. And those are some activities that we try to have patients refrain from. Specifically, sometimes overhead activities are those that we know that that cause pain.
Sure.
Some patients may have certain activities at the gym that they have some soreness participating in, or that may have soreness after the activity. And we usually tell patients that the pain that's experienced is a sign that there's a force and potentially some abnormal process going on in the shoulder that we might have them modify their activity in that regard.
Gotcha. Very cool. So with that tends to be more with the rotator cuff degenerative disease process that's happening. You mentioned another aspect of it, which is more the trauma induced. Is there a certain population that you see that happening more in? Is that happening more in the younger populations that are more athletic and have the higher tensile forces going through the shoulder area?
Sure. So traumatic tears we see in essentially younger and older patients alike. Mm-hmm. Traumatic tears are usually the result of a large torque that's applied through the arm from a traumatic situation. It may include a car accident, a fall from a height. Some patients that are a little bit older may also have possibly even an unknown degenerative process occurring in the shoulder, may not even know it, and then there could be a minor tearing process that then is substantially exacerbated at the time of the traumatic injury, which then causes the significant tearing process. We see these in association with dislocations sometimes in older individuals, sure, where there's an avulsion of multiple tendons at one time. And then even sometimes in younger patients can also, some of whom are overhead athletes, may have processes occurring that cause different patterns of these. So you could think of them as traumatic tears, but they're not necessarily caused by a force at one time. But all of these are different processes that can be kind of lumped into this traumatic tearing process.
Interesting. So if somebody's listening right now and they themselves are an overhead athlete, or maybe they're a parent of an overhead athlete, whether it's a baseball or football, or I guess volleyball would fall into that as well, maybe swimming, what kind of things should they be thinking about for either themselves or their kids to try to help protect their shoulders? Are there certain things they can do to try to help protect their shoulders with these activities?
Sure, it's a good question. So there are certainly it's not a bad idea to have your shoulder evaluated if there is pain that's becoming associated with throwing or other overhead activities. Some of the initial rehabilitation for the shoulder does focus on balancing the kinematics of the shoulder as the actual ball and socket or the glenohumeral joint relates to the scapula. Because if you look at the anatomy of the shoulder, the way that we raise our arm in elevation is a concerted motion between not only the ball and socket but also the shoulder blade as it rotates on the chest wall. So improving the so-called scapular stabilizers is a large part of the initial rehabilitation of a rotator cuff or a shoulder pain, even in patients that have shoulder problems that are not related to the rotator cuff. But yes, certainly doing stretches and strengthening that do focus on some of those scapular stabilizers as well as a rotator cuff can be an initial way to help, particularly in throwing athletes, to help to condition the shoulder.
Sure.
Do you ever see a correlation? This is now off topic of the questions we planned, but something that we see a lot, as you mentioned, the scapular stabilizers. So these are the muscles, if we would be referring to the same ones, that would attach from the scapula to somewhere on the rib cage or on the spine, somewhere on that wall that you were mentioning. Do you find that the health of the spine and that rib cage, whether they might be like extra kyphotic or have some kind of abnormality, do you find that highly impacts what's going to happen to the shoulder down the line, or do you not really see a relationship there in your practice?
Yeah, I think that there without question is a relationship. We don't have a lot of data to guide us with different postural findings that may relate to kyphosis, et cetera, that says this individual is going to develop a tear or a shoulder problem and this individual won't. Sure. But we do certainly see that. We also see a very high incidence of so-called scapular dyskinesis, where there are patients that have some subtle abnormalities in the kinematics of the shoulder blade as it rotates on the chest wall. And we see a much higher incidence in some of those patients that develop shoulder complaints. But in terms of, is there a certain patient that we can predict developing a shoulder problem as it relates to a kyphotic posture, if you will? We don't really have that data or information yet, but there probably is an association that is there. And patients that do have postural issues, it probably is a good idea to have those looked at.
Yeah, because you would think like, okay, well, if the muscles of the scapula, that's where the entire rotator cuff gets to like recruit from, is how is the scapula being able to be stabilized, or is it not being stabilized, can really affect how everything else down the chain would work. So it's just kind of some thinking like Charlie and I and a lot of our colleagues like to play with, saying, oh, well, maybe it wouldn't be a bad thing just to strengthen this area because they got to be strong anyways, whether it's spinal muscles or the scapular stabilizer muscles and things like that. So I just wanted to pick your brain on that.
Absolutely. I think scapular stabilization is a large part of the rehabilitation of rotator cuff or mini shoulder conditions.
Very cool. Now, talk to us about the different kinds of shoulder surgeries that you do, because when Julie and I initially saw you present, I believe you were talking about either a surgical technique that was pretty new for the shoulder, or at least it was something that I think most people hadn't heard of, where you're essentially almost reversing like where the ball and the socket would be for the ball and socket joint of the glenohumeral joint. Sure. So can you talk to us about that and what populations you find that has a high success rate with, what degenerative processes that has a high success rate with, and just kind of go on that, because that was really interesting to us.
Sure. So if you look at the procedure I believe you're referring to is the reverse shoulder replacement. Mm-hmm. And the reverse shoulder replacement is I'd say is a relatively new technology. Mm-hmm. It was initially developed in France by a physician by the name of Grimaud. And it's really exploded with regard to its application for shoulder disorders, as well as its use in the shoulder replacement realm, if you will. Some of the initial reverse shoulder replacements were done in the late 90s and early 2000s, initially in the United States, and it received FDA approval in 2004. And the initial indication for the reverse shoulder replacement was a condition known as rotator cuff tear arthropathy, whereas we talk about the rotator cuff as a tearing process progresses and gets very severe and leads to what's called an unrepairable or an irreparable tear. What can happen as a result of the actual instability of the joint can undergo a progressive degeneration, and that leads to a so-called arthropathy. And in those patients, we learned through our experience in shoulder replacement is that you really can't reliably perform a conventional shoulder replacement, which is just resurfacing the ball and socket, because it's not stabilized by anything. There's too many rocking horse types of forces going through the shoulder. Those fail. Not only do they fail at very, very high rates, but they don't have durable functional improvement. And so the reverse shoulder was initially proposed as a procedure to flip the concavities of the shoulder, where effectively the ball or the sphere is actually fixated onto the socket portion of the shoulder, and then the socket is fixated onto the humeral part of the shoulder. And as a result of that, what happens is that the fulcrum and the center of rotation is immediately fixed by flipping the concavity. And that then recruits the other muscles, specifically the deltoid muscle, to function as the motor of the shoulder. Gotcha. So the shoulder then, at that time, will have a stable fulcrum for motion and function, and has a motor which effectively allows the arm to be positioned in space and to be elevated overhead and some of these other things. Sure. And we've realized that the reverse arthroplasty, as the technology for it has continued to kind of evolve, its applicability to a variety of different shoulder conditions has also accelerated. For example, there are patients that have problems that have very severe deformities of the ball and socket from extremely advanced arthritis that have an intact rotator cuff, and we see a little bit of a higher incidence of problems in some of those shoulder replacements that are performed in those settings, whereas the reverse shoulder has come through and it's been a very durable and effective, long-lasting and predictable treatment option for some of those patients. There are other applications for it for severe fractures and some other things. But I would say in general, it has definitely, the use of it is gotten greater and greater as the years have gone by.
That's really cool. And what I liked, you brought up the point that was my next question, and then you touched on it, was the idea of, all right, if you're switching where the ball is and where the socket is, like you're saying, you're essentially switching the axial placement, but because it's the humerus moving on the scapula, yes, the scapula is going to have some motion in place. The axis itself is staying relatively fixed outside of the upward rotation of the scapula, allowing you to use your deltoid muscles more because of the fixed. Was I understanding that part correctly?
Correct. So if you look at what happens in rotator cuff arthropathy, is that the humerus effectively dislocates out of its position on the socket because there's no tendons anymore that are holding it in position. And again, it gets back to the mechanics of the way that the shoulder normally functions. If there's no rotator cuff holding that ball in that shallow dish, it's going to start to kind of sublux and shift out of the shoulder. And as that occurs, there's really no fixed center of rotation or fulcrum that allow the deltoid or some of these other muscles to really effectively move the arm.
Sure.
And as a result of that rotator cuff deficiency, the shoulder starts to progressively lose function. The tearing process becomes quite severe, and when the reverse shoulder is implanted, effectively what happens is the shoulder is immediately fixed with regard to its center of rotation, and there's an immediate fulcrum that then immediately allows the deltoid to lengthen and recruit and to become recruited to function as the motor of the shoulder for function.
Very cool. That's really neat.
And when you switch where the ball is and when the socket is, do we still see, like when someone raises their arm overhead, are we still seeing that upward rotation of the scapula, or does that really change the role of the scapula now, since it now has this ball on it?
We absolutely do. In fact, if you have a patient, for example, that has a shoulder fusion, in other words, that has absolutely zero motion in the actual shoulder itself, they will have a fair amount of elevation of their arm that's exclusively scapulothoracic motion. So without question, there still is a scapulothoracic component to getting the full function out of the shoulder.
Gotcha.
If you look at the actual mechanics of the normal shoulder, there's about 2 parts of glenohumeral motion and 1 part scapulothoracic motion. So yes, the so that's another reason that rehabilitating the scapulothoracic muscles, even after a shoulder replacement, for example, the reverse, is still an important component to the rehabilitative process.
Very cool.
Nice.
So is this what you were learning when you were in France? You said it was developed in France.
Yes. I worked with a variety of surgeons, one of whom was Gilles Walsh, that was one of the pioneers of reverse shoulder. Some of the other things that, that I was able to pick up in France are some of the different techniques and kind of theories that are used here, but probably far less frequently. For example, there are patients that have severe dislocation problems, or that have failed prior dislocation type surgery, specifically for the soft tissue repair, that then have issues like bone loss, where there are procedures that were initially pioneered in France and they use far more frequently there as their kind of primary treatment, that allowed me to get exposure to those things that now I can utilize here as somewhat of a reconstructive or an option for a patient that's had a prior failed type of procedure. So I think that getting it, we think in general, when we think about shoulder surgery, we definitely think of France as having thought of a lot of these complex and procedures that we use here a long time before we would have actually applied them here. So it was interesting to have that exposure.
That's really neat. That's
awesome.
Very neat.
So when people are post-surgery, let's say you do need to go in and intervene in some way, surgical way, what is the the projection of movement, getting back to lifestyle activities, getting back to exercise post-surgery, or does it depend? It
definitely depends, and there are patients that sometimes have relatively what I would consider minimal shoulder surgery. For example, they have a painful acromioclavicular joint, let's say, where the collarbone part of the shoulder is very sore and irritating. Patients will have a procedure to address that problem, and they discontinue the sling after a few weeks, really, and we tell them that it's really only for comfort. Those patients will have a relatively expeditious return to function and have relatively controlled pain after sometimes just a week or 2 at most after the operation. There are patients sometimes that have more severe soft tissue problems, for example, a massive rotator cuff tear, let's say. Some of those patients have to remain in the sling while the biologic healing process starts to initiate, which can, as you can imagine, take several weeks. And so those patients, we do delay their rehabilitative exercises with the arm to make sure that we've maximized the healing potential of the tendon. So I would say it definitely does depend. It also depends on whether they're having a replacement as a soft tissue type of problem, but it definitely depends on the patient.
Sure.
Does it also depend? I feel like in the beginning we kind of said there was like these chronic type stuff, and then these acute, maybe like more injury based issues. Do you also see a huge difference in recovery relative to what created the problem, whether it was chronic or an acute issue?
I would say so. I think yes, it does depend on whether it's an acute or a chronic disorder. It probably also relates to where the exact lesion is in the shoulder that we're addressing, whether it's the rotator cuff. As you can imagine, rotator cuff surgery doesn't improve overnight, and there is not only a healing process but a progressive rehabilitative process where we have interests that include letting the tissue heal, but then also preventing stiffness, getting the motion back, as we talked about, recruiting some of the scapular muscles. This whole process can sometimes take months for the full recovery to occur, but it's typically relatively predictable. And so there are patients that have more minor tearing processes that we can sometimes accelerate their recovery process, sometimes under the direction of a physical therapist, to make sure that we kind of expedite their recovery as much as possible.
Very cool. Very cool. So I saw in your bio that you work with a lot of the kind of local high school sports teams and whatnot, and you serve as the team physician, correct? Awesome. And so what kind of, are you dealing with all types of injuries there? Are you still focused on shoulders? Is it, what's your role in that regard?
I'm fortunate enough to be able to participate with athletes on many levels. As a result of my training, I also have experience with knee conditions, so I do treat patients for knee problems as well. There are a variety of traumatically induced injuries that include fractures, sometimes not necessarily of the shoulder or the knee, but of other areas that I can treat. And sometimes it's a matter of being there with the patient on the sideline in the clinic, kind of educating them on the problem, getting them a plan for return to activity, and providing recommendations to the coach, the athletic trainer, about what the timing of their planned kind of healing process is, as it will.
Sure. That's awesome. Very cool. Very cool. Well, hey, talk to us about, because you said, hey, you played college hockey, you played college baseball too, correct?
Correct.
Wonderful. And so what are you doing now for, to keep up your own health and well-being from an exercise standpoint?
Sure.
Or just,
So for my own health and well-being, I initially played a fair amount of hockey when I was a resident. As you can imagine, with the hours, sometimes it gets a little bit difficult to really fully commit to a team. So it was kind of this part-time fill-in that I enjoyed doing on a couple of different levels. But once I moved to New York to start my fellowship, you can imagine that it became difficult to kind of keep up with the hockey gear.
Sure.
The living arrangements are probably not ideal in Manhattan. So I gave up hockey for that period of time, and then moving back just with getting into practice and getting busy. I haven't had a lot of time to really return to hockey. I do miss it, but now I try to participate in running. I sometimes will go to exercise classes or fitness classes and try to do aerobic activity.
Sure.
Maintain some degree of physical fitness.
Yeah.
Even if it doesn't mean participating on a full team. Or spending a ton of time on it.
No, absolutely. Well, what I really like about that is, look, you're swamped in your practice. Not only that, but you're serving as a consultant for all these different sports teams. So you have a lot on your plate, and yet you're still put an emphasis and priority on maintaining your own health, on maintaining your own physical fitness through exercising, and that's awesome. That's such a valuable testimony for people to hear of why you need to keep exercising, even regardless of what else is on your plate. And yes, it may not be as much as you want. You may not get to do the exact things that you want, but making sure that you're finding the time to get something in on a regular basis. It's something that Julie and I preach all the time. Look, it doesn't have to be perfect. It just has to get done. You got to do something. So,
I agree.
Yeah.
But also the changing with wherever you are in your life. So I think that's another important thing, especially when we see people that are, maybe in their 40s, 50s, and 60s that are like, well, I played football in college, and if I can't do that, then all this workout is, not good enough, or it's not enough. So it's good to see that, not only us are saying you got to change what you're doing to fit your lifestyle so that you're, still staying active and staying healthy.
I agree. It's important for everyone. It's also somewhat of a release for me, with the schedule and
for sure,
clear my mind a little bit.
Sure.
For sure. So for our listeners, is there anything that you would recommend them doing if, hey, right now, let's say symptomatically, they're feeling good with their shoulders? Is there anything that you would recommend them doing to try to make sure it stays that way? Things they should add in, things they should avoid?
It's a good question. I don't know if there's anything specifically that I would tell someone that has absolutely zero pains or has never had a problem with their shoulder.
Sure.
I tell them enjoy their activities. Perform. Go ahead, go to the gym, do the activities that you enjoy. I think that the first clue that there's something wrong that we definitely need to target is certainly when a condition becomes painful.
Sure.
Because that oftentimes is associated with some degree of structural abnormality that we sometimes need to get some information on. But we don't really know whether or not there's patients that should preemptively or prophylactically undergo a guided, rehabilitative protocol, because we don't know whether or not that will prevent the problem from occurring. If patients have time and an interest, certainly if there are exercises that they want to perform that are specific to the rotator cuff, I certainly don't think it's a bad idea.
Awesome. And then once things do start to become painful, I mean, that's definitely the time that they should be calling you, that they should be connecting with you. And so how could our listeners connect with you? What's...
Sure. So I'm part of Barrington Orthopedic Specialists. We have 4 office locations. I see patients at 3, as we were discussing previously, in the Schaumburg location, in Bartlett, as well as in Elk Grove Village. Probably the easiest way to come in for an appointment would be to call our main number.
Wonderful.
847-285-4200.
Perfect.
And we're very good about making ourselves available to patients. Oftentimes on a same-day type basis.
Wow, that's awesome.
I try to make myself available whenever possible.
Great.
That's a phenomenal turnaround. Yeah.
Yeah, and one of the reasons that we requested that Dr. Obermeyer come on our podcast, because we did get to speak to him briefly, and it just seemed like his brain was exploding with knowledge. So I know that if you go see him, he will be able to educate you fully on whatever you're going through. And we certainly felt that way when we saw him present. We're like, we got to get this shoulder guy in.
Exactly.
Well, thank you.
We're anatomy freaks, and he just put up an anatomy picture of like the glenohumeral joint on the screen. So we were in.
It was the best morning meeting ever.
Oh my gosh. We walked away. We're like, this was the best one because we got a little anatomy lesson, and
fantastic.
We're totally
that was wonderful.
I think it's fun. It's interesting. So
for sure,
if you come in, it'll be an interesting and informative.
Yes,
definitely. So the question that we like to wrap up with is, Dr. Obermeyer, what is your definition of health?
My definition of health would probably be the absence of disease. Health, I think preventing disease, as we discussed previously, sometimes does incorporate exercise and some of these other things, diet. But my definition would probably be the absence of disease.
Wonderful, absolutely. And I think we're very fond of that definition here as well, because and I think disease, to the points that were brought up earlier, does not necessarily mean like full-blown end state. It's like, even absence of the disease processes starting before we even getting there. So
absolutely,
right on.
Great.
Awesome. Well, thank you so much for joining us. We really, really appreciate your time and your expertise. And
thanks for having me.
Oh, yeah, for sure. Definitely. Now, for our listeners, again, if you want to connect with Dr. Obermeyer, you got to check out Barrington Orthopedics, okay? You can find them online. Say the phone number one more time.
847-285-4200.
Wonderful. Give that number a shout. If you think, you have something funky going on with your shoulders, definitely connect with Dr. Obermeyer, because as you can tell, he knows his stuff. And so right on thank you again.
My pleasure. Thanks again for having me.
Absolutely. Well, for our listeners, thank you so much for tuning in. We always appreciate you spending your time with us. If you wouldn't mind, head on over to iTunes, leave us a rating and review. And who do you know that has something funky going on with their shoulders? Share this episode with them so they can learn about Dr. Obermeyer and the awesome work that he is doing. Have a fantastic week, and we'll talk with you all next week.